ஸோ இங்கே இருக்கிறவங்களுக்கு எத்தனை பேருக்கு தெரியும் நம்ம கற்கிறதுக்கு ஒரு யூடியூப் சேனல் இருக்குன்னு தெரியுமா? யாரா எத்தனை பேர் ஆக்சுவலி லாகின் பண்ணி ஏதாவது பார்த்துருக்கீங்க? வீடியோஸ் லைக் ப்ரெஸ் பண்ணியிருக்கீங்களா? சப்ஸ்கிரைப் பண்ணியிருக்கீங்களா? ஷேர் பண்ணியிருக்கீங்களா? ஷேர் பண்ண மாதிரி தெரியலையே. நாங்கள் இது ட்ராக் பண்ணுறோம் என்ன நடக்குது நம்ம யூடியூப் சேனல்லன்னு சொல்லிட்டு. நீங்களாம் நம்ம பண்ணுறது வந்து உங்களுக்கு உபயோகமாக இருக்குதுன்னு நம்புறீங்களா? இந்த கற்கந்து செஷன் வந்து உங்களுக்கு உங்கள் ப்ரொஃபஷ்னல் லைஃப்லேயோ இல்லை இன்டர்பர்சனல் கம்யூனிகேஷன் எதுலையாவது ஹெல்ப் பண்ணுறதுன்னு நினைக்கிறீங்களா? நோ? ஓகே. ஸோ உங்கள் ஃப்ரெண்ட்ஸ் ஆர் ஃபேமிலி மெம்பர்ஸ்க்கு அதர் ப்ரொஃபஷ்னல்ஸ் மற்ற ஹாஸ்பிட்டலில் வேலை செய்கிறவங்க மற்ற ஸ்டேட்ஸில் மற்ற கண்ட்ரீஸில் உங்களுக்கு தெரிஞ்சவங்களுக்கு வந்து இந்த மாதிரி ஒரு ப்ரோக்ராம் நடக்குதுன்னு சொல்லியிருக்கீங்களா? சரி. ஸோ சொல்லியிருக்கீங்கன்னா ப்ளீஸ் சொல்லலைனாலும் இப்போ சொல்லுங்கள். அண்டு யூடியூப் சேனலில் சப்ஸ்கிரைப் பண்ணிவிட்டு நீங்கள் லிங்க் ஷேர் பண்ணிங்கன்னா அவங்க எந்த டைம் ஜோனில் இருந்தாலும் அவங்க எந்த மாதிரி வேலை பார்த்துருந்தாலும் அவங்க இஷ்டத்துக்கு அவங்க டைமில் பார்க்கலாம் இல்லையா? இட் இஸ் அவைலபிள் 24/7 ஃபார் டு வாட்ச். ஸோ டாக்டர் ராதாகிருஷ்ணா இஸ் கண்டினியூஸ்லி சப்போர்ட்டட் அஸ். ஹீ சென்டிங் அ வீடியோ டீம். அவங்க வந்து அவங்க டைமை ஸ்பெண்ட் பண்ணி அதுக்கு அவங்க மணி ஸ்பெண்ட் பண்ணி வராங்க. அதுக்கப்புறம் பின்னாடி போய் எடிட்டிங் எல்லாம் பண்ணி அப்லோட் பண்ணி நிறையா வேலை நடக்குது. ஸோ அதோட பலன் நமக்கு ஒண்டி இல்லை, மற்ற பேருக்கும் அடையணுங்கிறதுக்கோசரம். நமக்கு எதுவும் none of us is going to get publicity or நம்ம இன்னும் இது இன்ஃப்ளூயன்சராக மாறிட போகிறது இல்லை. ஜஸ்ட் ஃபார் த சேக் ஆஃப் ஷேரிங் நாலேஜ் ஐ ரிக்வெஸ்ட் தட் ஆல் ஆஃப் யூ ஷேர் அண்ட் சப்ஸ்கிரைப் டு அவர் யூடியூப் சேனல். ஸோ இன்னித்து டாபிக் என்ன? ஹைப்போதர்மியானா வாட் டஸ் இட் மீன்? வாட் டெம்பரேச்சர் இஸ் ஹைப்போதர்மியா? What is the normal body temperature? என்ன டிகிரி? இல்லை 98.7னா என்ன யூனிட்ஸ்? நம்ம மெடிக்கல் ஃபீல்டில் இருக்கோம். எஸ், we will not use any numbers without the units. ஓகே. பொட்டாசியம் 5.5 சொல்ல மாட்டோம். ஒன்றுனா மில்லி ஈக்குவலன்ஸ் பெர் லிட்டர், மில்லிமோல்ஸ் பெர் லிட்டர், ஹீமோக்ளோபின்னா கிராம்ஸ் பெர் டிசிலிட்டர் அப்படி இல்லையா? ஸோ வாட் இஸ் ஸோ 98.6ன்னு சொல்கிறோம் ஃபாரன்ஹைட்டில். What do we say in degrees centigrade? Yeah, right. So significant hypothermia na எவ்வளோ? 36.9 கூட நம்ம ஹைப்போதர்மியான்னு சொல்லலாம். 37லேருந்து ஒன்று குறைஞ்சிருச்சு 0.1. சிக்னிஃபிகண்ட் ஹைப்போதர்மியானா நார்மலாக என்ன? Yeah, so after 35 you should be really worried. Sometimes இப்போ நான் ரொம்ப நாளைக்கு இந்த ரூமில் தனியாக உட்காந்து இந்த ஏசி ஆன் பண்ணி என்னோடய டெம்பரேச்சர் 36 ஆகிடுமா இருக்கும். பட் 35 ஆச்சுன்னா we are going to start worrying இல்லையா? ஸோ does anyone know what is the lethal triad? ER டீம் தவிர வேறு யாரோ பதில் சொல்லுங்கள். lethal triad of trauma அப்படின்னு சொல்கிறது என்ன தெரியுமா? ட்ரையாட்னா என்ன? what do you think a triad means? triangle, triathlon, triad, what is it? Number 3, right? So what do you think is the lethal triad of trauma and shock? இன்னித்து டாபிக் இருக்கிறதுனால பேசுகிறேன். அதில் ஒன்று எடுத்து விடுங்க. ஏதாவது என்னவா இருக்கும்னு நினைக்கிறீங்க? அந்த 3ல் ஒன்று ஹைப்போதர்மியா. You're talking because it's hypothermia. Okay, so hypothermia, acidosis and coagulopathy, these 3 are considered the lethal triad in trauma. இந்த 3 வந்து ஒன்றுனால இன்னொன்று ஆகும். அப்படி hypothermia will worsen acidosis will worsen coagulopathy, and everything patient will bleed more because of coagulopathy, and then eventually they'll die. ஸோ இது வந்து ஒரு போனஸ் கொஸ்டின். இப்போ டயமண்ட் ஆஃப் ட்ரையாட் ஆஃப் டெத்துக்கு பதிலாக டைமண்ட் ஆஃப் டெத்துன்னு இப்போலாம் சொல்கிறோம். அது 4வது என்ன தெரியுமா இருக்காது? anyone can answer. Doctors, nurses, anybody, consultant, anyone can answer. What do you think is the 4th thing that has been recently added? Okay, that is outside syllabus, hypocalcemia. So now I request 3M company person to make a short presentation, and then நம்மளோட characteristic role play வந்து டாக்டர் செந்தில் and team அப்புறம் பண்ணுவாங்க.
So good afternoon once again. The topic is on the hypothermia management. So the objectives are to define normothermia and how it is regulated, define unintended perioperative hypothermia and why it is required to maintain the normothermia, and what are the current modalities available in the healthcare setup for maintaining the temperature for the patient. And what is FAW? Can anyone say what is FAW? So FAW is a forced air warming therapy. Why it is recommended by the organizations, and what is the output if you use FAW, that is a forced air warming therapy for the management of hypothermia and temperature management products of 3M. So this is what the objective of today's session. So normothermia and the body's response to the thermal change. So normothermia is ideal temperature or thermal system of the human. So as ma'am said, if it is goes below or if it goes high also, there will be a complication, expected complications for the patients. But the core temperature that we are expecting is 37 or 36.8 degrees centigrade to 37 degrees centigrade is what we consider, and the theoretical basis also given the baseline of 37 degrees centigrade is a normothermic temperature level. And there is a two temperatures we can see in the body. One is the core body temperature and the other is a peripheral temperatures. If you compare core body temperatures with the periphery temperature, there will be a plus or minus 2 to 4 degrees centigrade variations will be there with the core body temperature and to the peripheries. So the behavioral response, it includes, we usually respond to the temperature. How? If we lose temperature, if we start shivering, we will add some clothes to maintain the normothermia. That means to maintain the temperature, we will wear clothes. If you are exposed or if you are facing some extreme hot temperature or we are getting a hypothermia, then we will expose or we will loosen the clothes to expose or to maintain the normothermia of the for a body condition. And there is an ambient temperature. So the team will be acting out on the ambient temperature. Why it is important? Because as ma'am said, if you sit inside the room with the same temperature for a particular period of time, you will also lose your body temperature. So that is one of the response that we will do it. Because if you expose or if you feel that we are going with shivering, we will maintain the ambient temperature, that is your room temperature. We will either we will reduce or we will increase the temperature of the room, and moving towards the warmer or cooler areas. If you feel cool, definitely we will go to some hot place. Like in the December month, we used to show our palms to the fire, so flames. That is one of the example over here for a behavioral response. And body's response to cold are vasoconstriction, NST, and shivering. Body's response to heat, we respond in vasodilation, as well as we can expect sweating on the hypothermia, that is your heat temperature. And hypothermia, so as we all we discussed in the previous slide, so anything that is goes below 36 degrees centigrade or 35 degrees centigrade, we call that it is a hypothermia. And as ma'am said, 36 degrees centigrade we can consider, but if it goes below 35 degrees centigrade, definitely the patient should need some assistance or medical, we consider that it is a medical emergency to treat out. And we also call this hypothermia, especially in the perioperative period. We call perioperative hypothermia as well as inadvertent perioperative hypothermia, and unintended hypothermia is also one of the reason or one of the thing that you can expect on the perioperative stage. So what is unintended hypothermia? Any idea? What is unintended perioperative hypothermia or hypothermia? So we will see that. I will explain what is unintended hypothermia. So all surgical patients, irrespective of their age, body weight, BMI, and the disease condition, all the patients are expected to develop hypothermia during their perioperative stages, either in the preoperative or intraoperative or postoperative. We expect 50 to 80% of the patient who is undergoing a surgical procedure are developing hypothermia on the faces. we would have seen when the patient is transferring from the OT to a pre-anesthesia or a PACU unit after the surgical procedure, we will shift the patient with a lot of blankets over the patient. We will also hand over the staffs that the patient is having so much of temperature, so we have put some blanket, and monitorly we have to hourly monitor, or QTH we have to monitor the temperature. So that is what the expectations here also. And there are adverse effects of unintended hypothermia. There are negative outcomes if that hypothermia is not being taken care. So what are the negative outcomes? The first outcome is increased rate of wound infection. Though these things you can expect in the post-operative period, but increased mortality rates. If the hypothermia is not maintained, definitely the mortality rate will be the highest trend. And coagulopathy, as ma'am was talking about coagulopathy. So if you are not, or if you fail to treat the hypothermia on time, definitely that will also cause coagulopathy for the patients, and prolonged and altered drug effects. Myocardial ischemia, sometimes if that is not treated, then myocardial ischemia and cardiac disturbance also one of the negative outcome. And shivering and thermal discomfort, delayed emergence from the anesthesia is also one of the negative outcomes of unintended perioperative hypothermias. So what is the primary cause of perioperative hypothermia? There are a lot of causes, but primary cause of any hypothermia for the surgical patient or this aspect of surgical thing. So the anesthesia is the primary cause for developing hypothermia. That is your redistribution temperature losses there. So that's why we are expecting unintended hypothermia on the surgical patient. Especially general anesthesia and regional anesthesias, there is a that we can expect a hypothermia for the patient. And cold over temperature, of course, that is what we have seen in the previous slide also. So ambient temperatures, that is your room temperature or out of the surface temperature, that will also lead to a hypothermia there. Exposed body cavities, if a cavity is exposed for a long period of time, then you can also expect a hypothermia for the patients. And infusion of cold fluids, we will be rushing, or we will be infusing a lot of IV fluids for the intraoperative patients, that is surgical patient. We will rush RS, RL, NS, whatever it is. But those solutions can also cause hypothermia to the patients. And length of surgery, of course, more than 4 hours of surgical procedure, it is recommended to put a warming blanket, or warming is necessary as per the guidelines of AORN and the rest of the organizations. And blood or fluid loss, more than 1500 ml of blood loss is there, then we need to have a watch on the patients whether the patient is going for a hypothermia or not. And blood loss and fluid loss also can cause hypothermia to the patients. Wet skin preparation, if the skin preparation is not dried properly, of course that will also lead to a hypothermia for the surgical patients. So effects of anesthesia. So what happens after the anesthesia to the, or if the patient is sedated for the surgical procedure. So as we all know, it is not a scientific over here. So once the general anesthesia or anesthesia was given, our body and muscles goes to a relaxed condition. Vasodilations will happen, and arterial shunts will also gets open. Because of that, there will be a mixing of bloods. If you look at the pictures, we have put it here. So 2 to 4 degrees centigrade of sudden loss on the first hour of the anesthesia has been given. And that there is a term called RTD, redistribution temperature drop. So because of the vasodilations and the arterial shunts are opening, if you look at here, the red color blood and the peripheries will be having a slightly less temperature blood compared to your core body, because once the dilations happen, this warm blood and the cold blood will get mixed with each other, and that can cause a hypothermia to the patients. There the blood will lose that core body temperature. So that is what the RTD, that is redistribution temperature drop. So characteristics and patterns of general anesthesia induced hypothermia. So this will be having a 3 phases: phase 1, phase 2, phase 3. That is a rapid decrease in core temperature. So this develops immediately after the induction. That is what I told. Within the 1 hour of induction, you might expect 2 to 4 degree drop on the core body temperature. So that is what the data also available. And core body temperature can drop up to 1.6 degrees centigrade in the first hour of general anesthesia. And the second phase is a slow and linear decline in the temperature. So first 1 hour you can expect 1.6 to 2 degree centigrade drop on the core body temperature. After that, you will be expecting a linear and slow decline on the temperature drop. So that is what happens in the second phase. Results from significantly decreased metabolism due to anesthesia and diminished heat production by the muscles, because the muscles will be in the relaxed condition, the metabolism will not happen. Because of that, the linear or the gradual temperature drop is happening or expecting on the patient. The last phase is a temperature plateau. So that is after 3 to 5 hours of sedation, you can expect this phase. So a re-emergence of thermoregulatory vasoconstrictions and re-establishes the normal temperature, and gradient core temperature will be plateau. So the studies are shows that 81% of temperature decrease is due to core peripheral heat distribution. That is what RTD. So 81% of hypothermia is happening because of your RTD. And the guidelines. So is there any guidelines to follow, or says it is necessary for the patient to undergo a warming therapy? Yes, there are a lot of organizations recommending warming therapy is most important for the surgical patient. Out of that, we have displayed few things over here for the reference. And if you ask for the studies, there are multiple studies available, but for the time sake, we have published only two for your reference. That is Hong and Miller study. This was done on the surgical site infection reduction data. The study they have done on the patients, and it is not only on the warming therapy, but this study is having a checkpoint of warming therapies. It has a multiple checkpoints. Out of that, one is the warming therapy checkpoints. So the study declines or says that implementation and adherence to the checklist significantly reduce the number of SSIs. So this is what the study results they have found. But if you look at there, half an hour of warming before surgery and warming during surgery using a forced air warming gown, additional components also included in that study. But 30 minutes before your surgical procedure, the study recommends to warm the patient to prevent the RTD. If you do a warming protocol half an hour before the surgical incision, definitely you can able to manage and you can prevent the RTD for the patients. And this is the second study, Sessler studies. This is published in the year 1995. This study only on the temperature of pre-warming was done, and the study findings are it indicates 30 minutes of pre-warming with forced air warming therapies. So why we have displayed the forced air warming therapy publications are, that is the only recommendations available on the portals, that is the organizational portals. If you search for the warming therapy, these are the only recommendations, and we will also see in the coming slides. Pre-warming can prevent and reduce the RTD for the patients. Only 30 minutes before of pre-warming can help prevent redistribution temperature drop. That is what RTD. And pre-warming plus intraoperative warming can help the patient to overcome the hypothermia, and it is very helpful for the patient to not to have any negative based or negative things of the negative outcomes of the RTD. So what are the techniques available? We will be having lot of, or you would have seen lot of technologies nowadays for the warming therapies. But basically, if you look at the warming protocols, there are two things. One is passive and active warming therapies. So passive warming therapies is what we usually in the conventional periods we used to have blankets. We will be having a tough or high density of blankets. We used to cover the patient with blankets. So those things are passive warming therapies. And the difference between the cotton blankets and fluid warming therapies. So this comes under a passive warming. So that's why we are discussing here. So passive warmings will increase the temperature or maintain the temperature for the patient, but not to our expectation, because we wanted to maintain the patient's normal temperature with a 36 degrees centigrade or maybe 36.8 to 37 degrees centigrade. But if you put or if you use a warming blanket, that is your linen blankets for warming the patient, that is not going to achieve, because after a period of time within the temperature, or if it is on the AC, definitely our clothes will also become chill. Okay, so many of the times we will be wearing a sweat coats, but if you are on the AC, definitely your sweat coats will also become a cool for your temperature after a particular exposed time. But that is not going to help for the post-operative patients or the surgical patient, because already the body cavities has been exposed to the environment. That is one cause. And warming the woolen or the cotton blankets itself will become a cool in nature after a particular period of time. So those two things will not help the patient to overcome the hypothermia. So cotton blankets, fluid warming. So there are practices of fluid warming where they will be having a warming cabinet. They will put RLNS into that cabinet, and they will also try to infuse the warming salines and warming fluids for the patient. But ideally, that will help you out in the first initial period of time, but not into a fourth hour or fifth hour of surgical procedure. That is not going to help you in terms of maintaining the normothermia. And this is what the active warming methods. So we divide into convective and conductive methods. So the major difference here is air to surface warming is a convective practice, and conductive is surface to surface transfer of the heat. But both the areas, the heat will be delivered to the patient to maintain the normothermia. But surface to surface, it is not that much effective for maintaining the normothermia, because our body is not a straight body curvature. We will be having some blend or curved curvatures on the spine area, as well as we will be having a heel. When you put the patient on the supine position, all the bodies will not be exposed to the temperature pad or water mattresses. So there are practice water mattresses we use to warm the patient, and there are electrical blankets also available. But if you make a patient to lie over that blanket, the heels will be, the pressure points will be on the blanket, but the rest of the bodies will not be exposed or will not be in contact with the air, that is your water bodies. So here the convective will be very helpful, because if you use a disposable blankets and if you make the patient lie over that blanket, the warm air will be exposed to the entire surface of the skin. So it will give you a barrier of thing, like it will stick on to your skin, and it will be keep on delivering a particular temperature, and it will prevent the negative outcomes of the hypothermia. So this is what the expectation. And if you do a convective practice, the study says that it is recruits up to 64% of body, and the conductive practice will be recruits approximately 20% of the body's temperature. So that is what the study outputs, and these are the guidelines for using a forced air warming therapy. Your NICE guidelines, ASPON, and all the guidelines, AORN also now, NABH 6th edition also talks about forced air warming therapies. So pre-operative, intraoperative, and post-operative. Most of the time we thought that only on the intraoperative period the warming should be done or expected to follow the warming protocol, but it is not like that. So all the three phases of the surgical procedure, the patient has to undergo warming protocols. So pre-operatively, the guideline says before 10 minutes of or before 20 minutes of your surgical incision, the patient is supposed to go for a warming protocols. And intraoperatively, throughout the intraoperative procedure period, the patients are expected to maintain the normothermia, and the patient are supposed to go for a warming protocols and warming therapies. And post-operatively, till the patient is maintaining the normothermia, we need to ideally warm the patient for maintaining the normothermia. So forced air warming therapies. So this is the research articles we will be having on to say that how effective is the forced air warming therapy. We have done with the multiple practices, multiple methods of the warming therapy, like forced air warming therapy, space blanket and control, humidifier, everything. But out of that, we found the study shows that forced air warming therapies are preferably to maintain the normothermia for the patients. And at last, 3M will be having a lot of different components of warming blankets to maintain the normothermia for the patients. If you look at the picture, the first is a full body blanket where the patient is undergoing any cranial surgeries, neurological surgeries. You can cover the entire body of the patient and you can do your surgical procedure on the head. And the second two pictures are lower body blankets, where if you are performing any surgeries on the cardiothoracic regions or subclavian or on the joints, you can use below body blankets for warming the patient. And pediatrics also, we will be having pediatric underbody blankets. So we will not have any above body or full body blankets for the pediatric. Only underbody blankets are available in the market, and multi-axis blankets, that is a multi-portion blanket, where if you look at the pictures, you can utilize same blanket for the multiple shapes for the procedures. Whatever the procedure you want to do, or whichever the part you wanted to do a procedure, you can manipulate the size of the size of the blankets, and you can also use for the patients. So these are the 3M products available on the warming protocols, that is warming machine, forced air warming therapies, and blankets, and temperature sensor probes also available with the 3M. So any doubts? Thank you, ma'am. Thank you for giving the opportunity.
So the 3M company people will be available even after the session. If you want to, the people who have worked in OT would have already seen these blankets. For the others, the blankets will be available and they'll explain to you how to use it. Thank you for a very exhaustive talk. So they have set the stage for the role play. Now I request Dr. Sendil to introduce his team and do our signature role play.
Good afternoon to all for an interactive role play for today's section. So today's session or today's role play topic would be early detection, prevention and management of hypothermia for a patient in different phases of hospital. Okay, so let me take the opportunity to let all my team members get introduced. First, to start with the ER team.
Good afternoon, everyone. I'm Dr. Yuvraj. I'll be playing the role of ER physician. This is my staff nurse, Mr. Bhagat.
Hi everyone, I'm Albert Raja from CT technician from radiology department. Thank you.
I'm Kamesh from MSOT. I'm playing the role of surgeon.
Good afternoon. Myself Ritika, MSOT anesthesia technician.
Good afternoon. I am Pradisha. Today I have to play as a technician.
Good afternoon. I am Srinidhi from MSOT. I am playing anesthesia technician.
Hello, I am Dr. Gayatri from post-op duty doctor.
I'm Sister Jayaprada from post-op in charge.
Good afternoon. I am Ram Prasad. I am playing the role of anesthesia tech.
Good afternoon. My name is Mustaq, post-operative sir.
Okay, let's get started with the voiceover with the introduction of what is the case and how we are going to proceed on it. Thank you.
Good afternoon, everyone. So today we'll see the scenario of a RTA patient who comes with polytrauma to the hospital. Since today's topic is about hypothermia, we'll see the prevention, detection and management of hypothermia in different phases of the hospital. So the first thing is the patient is brought to the ER. A 60-year-old male is brought to the ER after a high-speed road traffic accident. He was found on the roadside approximately 45 minutes in rainy weather. So before the ambulance arrival. So we'll see what happens in the ER now.
எக்ஸ்கியூஸ் மீ சார், என்னாச்சு சார்? என்னாச்சு?
பேர் சொல்லுங்க சார். கண்ணை திறங்க. Bilateral air entry, respiratory rate of 16. Checking for pulse. Pulse rate of 126. Blood pressure 90/60. Peripheries are cold. Jesus around 11/15. Temperature?
Temperature 33 degrees.
Second 2 large bore needles. IV line. Remove his wet cloth. Change to hospital gown. Blanket. Try to arrange a warmer. And then warm saline. Get an ultrasound. Looking for secondary survey as well as the ultrasound e-fast. Fast is positive near the splenorenal angle. So you have to move him for ultrasound, get a sample, blood gas, arrange for a PTNR, urgent.
Taken sir under APG also. Blood gas also sir.
Alert the blood bank. Can we shift him for CT?
Okay sir, once I inform I will. ஹலோ சிடி சார், இயர்லேருந்து ஒரு பேஷண்ட் ஆர்டிஏ இமீடியட்டாக சிடி அப்டமன் எடுக்கணும். டெம்பரேச்சர் வந்து 33 டிகிரி செல்சியஸ் தான் இருக்குது. ஸோ டெம்பரேச்சர் வந்து இன்க்ரீஸ் பண்ணணும். சிடிஸில் வார்மர் மட்டும் ரெடி பண்ணி வச்சுக்கோங்க. பேஷண்ட் ஷிஃப்ட் பண்ணிக்கலாமா? ஓகே.
And also can we alert the trauma team as well as the surgeon on call today?
Okay sir. Patient shifted to CT.
You are received from CT scan from ER patient. Vitals என்ன இருக்குது சார்?
Pulse rate of 126, temperature 33.
சார் டெம்பரேச்சர் 33 இருக்குது சார். வார்மர் கனெக்ட் பண்ணிவிடுங்க ஃபுல் டைம். வி ஆர் கவர்டு சிடி அப்டாமன் பிளைன் பண்ணுறோம் இப்போது எமர்ஜென்சியாக வந்ததுலேருந்து. ஸோ அந்த ஏரியா மட்டும் கவர் பண்ணிக்கிறோம். வார்மர் கனெக்ட் பண்ணி விட்டுருங்க. ஓகே ரைட். Now CT scan completed sir. We are shifting the patient to ER.
Yeah. Surgeon sir, I have a patient 65-year-old male was found unconscious on his road. Exact mechanism of injury was not known. So we got an ultrasound fast. His temperature, ultrasound fast, it was positive. E-fast was positive. His temperature is around 33 degrees Celsius. Blood pressure 90/60 and pulse rate of 126. GCS is around 11/15. So we shifted him for CT. He has got a splenic laceration. So we alerted the blood bank. We kept our blood on reserve. As well as we alerted the labs. You want to shift for?
OT, sir. Sir, did you inform to the operation theatre?
Just I'm trying to reach them.
Oh,
we'll be
okay,
calling
sir.
them now.
Okay. பேஷண்ட்டோட ரிலேட்டிவ்ஸ்லாம் இருக்காங்களா சார் கன்சர்ன்?
ஒருத்தங்க வந்திருக்காங்க சார்.
ஓகே சார், தேங்க்யூ.
So since the CT came as splenic laceration, after discussion with the surgeon, the patient is shifted to the OT. We'll see the scenario in the OT now.
OT recovery room. So, sir, just let me know what is the patient detail.
So this is a 65-year-old male. Okay. Was found unconscious. Exact mechanism of road traffic accident was not known. Probably high velocity injury. And he was found like on the road. He was brought by ambulance.
Is GCS sir? Sorry to interrupt, so that I can have
15,
an idea.
Lumbar 15.
Okay.
Pulse rate of 126.
Okay.
Blood pressure 90/60.
Okay.
Temperature is around 33 degrees Celsius.
Oh. Okay. So he is hypothermic.
Hypothermic.
Okay.
So we send the routine samples for investigation and blood bank has been alerted. Fast has been positive. The first bedside was positive. We shifted him for CT abdomen. There is a splenic laceration.
Okay.
I spoke to the surgeon on call. Plan for splenectomy now.
Okay. So okay. And
last meal was not known, sir.
last meal was not. Okay. Another thing was the blood bank alerted in case of blood transfusion. Yes. Okay. So okay then. So brother, patient receive பண்ணிருங்க. Okay. So since it's an team, OT team.
Sir, identification check.
Yeah. Since it's an emergency, we'll do it in a fast track basis. Patient ID details, எல்லாத்தையுமே fast track பண்ணிட்டு.
Yes, sir.
We'll get proceed. Okay. We'll start with the safety pass. Patient ID details.
Sir, patient name Munnasamy, sir.
Okay.
Next.
One can check. With the floor. Okay. Okay.
Patient age 60.
Okay.
BP number 98765431.
Okay. ID card. Since fasting on the status நமக்கு inadequate இருக்கு clear-ஆ தெரியலன்றதுனால okay we'll go and so we'll plan a general anesthesia and rapid sequent induction will be our plan. Okay. So circles brother. Consent taken. Consent taken and all parameters checked.
Yes, sir.
Okay, fine. Okay. So we'll get started. Sister, standard monitors attach பண்ணலாம். Pulse oximeter. ECG. BP. Okay. Have temperature probe also ready. Okay. Okay. So ready. Okay. Since ER physician temperature low அப்படின்னு சொல்லியிருக்காரு hypothermicனு, so we'll standardize our OT ambient temperature 24 to 26 இருக்கணும். அது கீழே டிக்ரீஸ் ஆகக்கூடாது. ஓகே ஃபைன். ஓகே ஸோ வார்ம் பிளாக்கெட்.
OT temperature increased to 24, sir.
ஓகே ERலேருந்தும் CTலேருந்தும் வார்ம் ஃப்ளூயிட்ஸ் கொடுத்துருக்காங்க. வில் மெயின்டைன் வித் வார்ம் ஃப்ளூயிட்ஸ். மேக் ஷுர் இட்ஸ் ஆல் வார்ம் ஃப்ளூயிட்ஸ். இன்கேஸ் பிளட் வந்துச்சுன்னா ஃப்ளூயிட் வார்மரோட டிரான்ஸ்ஃபியூஸ் பண்ணும். ஓகே. Emergency. Okay. Okay. Oh. Temperature not? Oh. So it is hyper 33 also. Okay. Or what baseline vital monitors? Heart rate of 120, BP of 90-60, saturation of 96, and temperature of 33. Okay. We'll start inducing the patient. Okay. Or RSI korthar. Okay. Milder. So.
Sir,
Yes.
I'm scrubbing, sir.
Yes, please. Yes, sir. So we start inducing. Okay. Mild pre-oxygenation. Okay. Okay. Heart rate is 110. BP is 90-60. Saturation of 96. Okay. So it's a RSI now. We'll start inducing. Sister, anesthesia drugs கொடுக்க ஆரம்பிக்கலாம். Okay. Right. Okay. Okay. Timer on for relaxant.
Timer on, sir.
Yes. So one person monitor for the time. Okay. Time cross. Scope, please. Laryngoscope for the intubation. Okay. Yes. Cords visible. 8 size Portex CT tube. Okay. Scope out. Okay. Circuit, please. Hold on with the maneuver. Okay. Yes, inflate. Okay. Bag is adequate. Chest rise is adequate. End tidal is traceable. Yes, end tidal is also traceable. So we are starting with a heart rate of 120, BP of 90-60, saturation of 96, with a temperature of 33. Sister, body warmer, standard blankets, warm IV fluid with a fluid warmer. Ellame keep it ready. Okay?
Okay, sir.
Call the surgeon, please. Yeah. Next patient. Yes. Yes. Fluid on flow. Pattern. Yes. Make sure patient is adequately warm. It's a full blanket. Okay. No. ஓகே சார் ஹைப்போதர்மிக் அப்படிங்கிறனால அடிக்வட்டான இது மட்டும்தான் எக்ஸ்போஸ் பண்ண முடியும். ஓகே அதர்வைஸ் இட் வில் பி ஃபுல்லி கவர்ட். ஓகேங்களா? இட்ஸ் கரெக்டாக ஆம்பியன்ட் டெம்பரேச்சரை கரெக்டாக ஆப்டிமைஸ் பண்ணிட்டோம். 24-26 கீழே குறையாது சார். ஓகே. டேப்ஸ் ப்ளீஸ் ஹெல்ப் த சர்ஜன்.
Side sheets.
டியூப் பார்த்தேன். Sir, sheets are draped. You can proceed. Make sure we minimize the operating time also.
Sir, painting, sir.
Yes, sir, please. சக்ஷன் காட்ரி எல்லாமே பார்த்துக்குங்க. ஓகே,
Sir, starting, sir.
எஸ் ப்ளீஸ்.
Scalpel.
எமர்ஜென்சி, அதனால சேஃப்டி பாஸ் பார்த்துட்டு இது பண்ணுறோம். எஸ், கோ ஹெட் ப்ளீஸ். லெட் இட் பி ஷார்ட் அண்ட் கிறிஸ்பி. வி ஆர் இன் எமர்ஜென்சி. எஸ், எஸ், இட்ஸ் a splenic injury, so we are planned for an emergency laparotomy. Yes, please. Yes, okay. Antibiotic injection cefuroxime as per our guidelines. Okay, 1.5. Yes, please. Heart rate, BP, saturation, temperature additional attach பண்ணிருக்கீங்க. டெம்பரேச்சரையும் பார்த்துக்குங்க.
Sir, blood loss is more than 500 ml, sir. So we need to arrange the blood products immediately, sir.
ஓகே சிஸ்டர், பிளட் பேங்க் அலர்ட் பண்ணுங்க. ரிசர்வ் பண்ணி இந்த பிளட் ப்ராடக்ட்ஸ் ரெடியான்னு பார்த்துங்க.
ஹலோ சிஸ்டர். சிஸ்டர், எம்எஸ்ஓட்டிலேருந்து எமர்ஜென்சி லேப்ரேட்டமிக்காக பேஷண்ட்டுக்கு பிளட் ப்ராடக்ட்ஸை ரிசீவ் பண்ண சொல்லியிருக்கு. எமர்ஜென்சி லேப்ரேட்டமிக்காக பேஷண்ட் பிளட் ப்ராடக்ட்ஸை ரிசீவ் பண்ண சொல்லியிருக்கு. ஸோ 2 PRBC, 4 FFP and 2 platelets கொடுத்து விடுங்க சிஸ்டர். கொஞ்சம் வாமா.
ஓகே சிஸ்டர், உடனே அனுப்புகிறோம் சிஸ்டர்.
ஓகே சிஸ்டர்.
Sir, blood bank alerted. Products are on the way. You can proceed. Okay. Let me know heart rate, BP, saturation. எப்போ சொல்லணும் அப்படி. At least heart rate and BP. Okay. Okay. Okay, sister. Check for the product. Road balance. Okay. Okay.
March 1, 2026, expiry August 5, 2026, bag number 256, segment number 5235
LDPRBC. Okay.
Sir, everything is okay about the vitals?
Okay, sir. Heart rate is 110, BP is 90/60, saturation is 96, and temperature is 33. Warm blankets, warming sheets, everything is on floor.
Okay, sir.
Okay, sir.
Most
How is the finding, sir?
Sir, I am going with closure. Brother, sign out.
Sir, all counts correct, sir.
Okay. We are starting blood on it. Okay, let us start the blood, and you can we can start with the counts.
Instruments, gas counts correct, sir.
Okay. Okay. Have fluid warmer, sister. Make sure the blood is also warm, just like IV fluid. Okay? You need to be very optimistic on it. Okay. Is it the splenic injury only, sir? Intraoperative finding?
Yes, sir.
Okay. Okay.
Sir, procedure done, sir.
Okay, sir. So let me check with the vitals and let me plan extubation. Okay. Heart rate 100, BP 98/62, saturation of 97, and temperature of 35. So we'll plan extubation. We'll see the efforts and we'll plan for the reversal and we'll plan for extubation. Okay. Okay. Sister, get ready with the reversal. Okay. We are planning for extubation as of now, sir. Okay. So since sister, it's patient is hypothermic, alert the post-operative room also, and make sure their warmer sheet, blankets, and IV fluids which are warmed and the blood which goes with warm are readily available. Okay, so that the patient does not have a further decrease in temperature. Okay.
ஓகே சார். ஹலோ சிஸ்டர், எமர்ஜென்சி லேப்ரேட்டமி முடிச்சுட்டு பேஷண்ட் போஸ்ட்டாக போகிறாங்க. வார்மர் பிளாங்கெட்ஸ்லாம் ரெடியாக வச்சுக்கோங்க.
Patient efforts adequate இருக்கு. Okay. Heart rate is 100, BP is 160, saturation is fluctuating from 98 to 97. So we are planning to reverse the patient and extubate the patient. ஓகே சிஸ்டர், ரிவர்சல் கொடுக்கலாம். டாப் ஒரு வாட்டி செக் பண்ணிட்டோம் இல்லையா, ஃபர்ஸ்ட் பார்த்த மாதிரி டாப் கம்ப்ளீஷனுக்கு செக் பண்ணிட்டோம். ஸோ 4 twitches ரிவர்சல் அடிக்குவேட்டாக இருக்குன்றதை என்ஷூர் பண்ணிட்டு வீல்ஸ் கிவ் அவர் ரிவர்சல். ஓகே, ரிவர்சல் கொடுக்கலாம்.
Reversal given, sir.
எஸ், ரிவர்சல் given. Okay, just let out the fluid so that the drug goes. Okay, sir. Okay. Heart rate is 100, BP is 102/68, saturation of 98, and a temperature of 35. So we are planning to extubate the patient. Suction, air syringe. Okay. Okay, efforts are adequate. சிஸ்டர் பக்கத்தில் இருங்க, பேஷண்ட்டை எக்ஸ்டுபேட் பண்ணணும். பக்கத்தில் இருங்க, பேஷண்ட்டை ஹோல்ட் பண்ணிக்கங்க ஸோ தட் ஹி டசன்ட் ஸ்லிப் ஆஃப். ஓகே ஓகே. சக்ஷன், எஸ் ப்ளீஸ், சக்ஷன் இஸ் இன் deflate syringe. Okay, so patient, okay, deflated. Okay, positive pressure. Okay, right. Okay, mask, circuit. ஓகே சார், பேஷண்ட் போஸ்ட் ஆப் ஷிஃப்ட் பண்ணலாம். போஸ்ட் ஆப் அலர்ட் பண்ணிடுங்க.
So after an exhaustive surgery, the patient is shifted to the post-op and we'll see how the temperature is maintained in the post-op.
சிஸ்டர் வைட்டல்ஸ் செக் பண்ணுங்க சிஸ்டர். மானிட்டர் கனெக்ட் பண்ணுங்க. டெம்பரேச்சர் பாருங்க.
பேஷண்ட் முனுசாமி, 60 years male, abdominal injury, RTA. So emergency splenic injury, so emergency laparotomy.
Okay, sir.
Post-operative GA anesthesia கொடுத்திருந்தது.
Okay, sir.
So temperature was 33. வார்மர் பிளாங்கெட்டோட பேஷண்ட்டை வார்ம் பண்ணி வச்சிருந்தது. ஸோ எக்ஸ்டுபேஷன் அப்போ டெம்பரேச்சர் ஆஃப் 35.
Okay.
ஸோ எக்ஸ்டுபேட்டட் வார்மர் ஷீட்ஸோட வார்ம் ஃப்ளூயிட்ஸோட பிளட் வார்ம், we have warmed the blood and we have shifted.
Okay, we'll take care. வார்மர் கனெக்ட் பண்ணுங்க சிஸ்டர். 40 degrees வைங்க. 40ல வச்சிருங்க. வெட் ஷீட் வெட்டாக இருக்கான்னு பாருங்க. ஷீட்ஸ் ஏதாவது வெட்டாக இருந்தால் ரிமூவ் பண்ணிடுங்க.
பெட் ஷீட்ஸ் எல்லாம் ரிமூவ் பண்ணிட்டோம் மேம்.
15 மினிட்ஸ்க்கு ஒரு தடவை டெம்பரேச்சர் செக் பண்ணுங்க.
ஓகே மேம்.
ஆஃப்டர் 15 மினிட்ஸ் எவ்வளோ இருக்கு சிஸ்டர் டெம்பரேச்சர்?
மேம் இப்போ 37 இருக்குது மேம்.
ஓகே சிஸ்டர், ரெடியூஸ் பண்ணிடலாம். 40லேருந்து ரெடியூஸ் பண்ணி
மேம் 38 வச்சுருக்கேன் மேம் இப்போ.
ஓகே, now we'll check the vitals.
மேம் அதே தான் மேம் 36.6 இருக்குங்க மேம்.
Since patient is stable and temperature is maintained, we are removing the warmer. Sir, எப்படி இருக்கீங்க? குளிர் போயிடுச்சா? ஓகே.
சேச்சுரேஷனும் 99 இருக்கு மேம்.
So please give them a big hand. From a semi-conscious patient, hypothermia will also cause reduction in sensorium. So once you warm the patient and bring the blood pressure up, even the sensorium improves. The ER team will tell you that one of the common causes of altered sensorium in the ER is hemorrhagic shock. So any questions? A few things I'll just, because of the constraints of the stage and all, some modifications that to be done. You're not supposed to check the surface temperature when, especially in a patient who's hypothermic, you have to check the core temperature only. So either you should put, like how they showed in the theater, they are putting an esophageal probe or a esophageal temperature or a rectal temperature. Some places they have eardrum temperature measurement that we don't have. So if you check on the skin, they clearly explained by our speaker that there will be a gradient between the central and the peripheral temperature, even for you and me. Even both when we are all normal and in a warm temperature also, core and peripheral temperature there will be difference. So if you check hands and feet, it could be cold. So if patient is not conscious and you cannot take oral temperature, or you're not in a position to put a probe, then axilla is the next best. So this forehead temperature thing we are only using for screening. That is not what you would use. Okay. And clearly they mentioned in the beginning in the history itself, it was a rainy day. So why the wet clothes removal is one of the important steps when patient comes to a ER. In Chennai, we don't have big winter or snow and all, but if you work abroad, you may have patient who've been already exposed to cold temperature. That is why they brought the scenario that it was a rainy day, which means clothes are wet. So the wet clothes should be removed first and patient should be covered. It doesn't matter whether patient is hypothermic or not. Remove the wet clothes and cover the patient, and any trauma patient, put the oxygen. Those you don't need to even wait for vitals to be checked before doing all those things. So if anyone has any questions or comments, otherwise what you always wait for, we'll be on to the quiz. Any questions or doubts? So unfortunately the temperature does not rise as fast because we were doing a scenario, we just quickly raise the temperature. It's actually a very big challenge. It may take anything to 4 to 6 hours for us to increase. So today's, it was about forced air warming. So they showed you a lot of data about forced air warming. But there are other things are equally important, like humidified oxygen, which is heated humidification, which is practiced in the ICU and the operating room. And similarly, warm fluid is very important. Your bear hugger and all will not work when you're giving large volumes resuscitation, like patient has lost 3-4 liters blood, or if they're doing a major hepatectomy or patient is actively bleeding and you're rushing fluids, no forced air warmer will be able to catch up with that warming. So all the components are important. Prevention, that is keep the patient in the ER. When polytrauma comes, you should switch off the AC. Doesn't matter if we are sweating. If patient has come with hypothermia, we'll suffer in the warmth, but we'll keep the patient warm. OT, we cannot do that because of surgical site infection problem. So we are forced to keep the OT temperature, but there'll be some orthopedic surgeons and all who will want 16, 18. Those people, we have to tell them, sorry, like Sendil said, it will be maintained from 22 to 26, not less than that, just like how you do for pediatrics. Today was adult, pediatrics is a different ball game. So every factor, so measuring, unless you check the temperature, you will not know. Of course, if you touch itself, patient may be cold, but you won't know the degree of hypothermia, especially core temperature. Only if you measure, you will know. So core temperature should be measured. We should prevent further drop in temperature by removing wet clothes and keeping the patient covered and keeping the ambient temperature little higher than what. Okay, then you will decide on how much is the hypothermia, and that is why Jayaprada clearly demonstrated how for different degrees of hypothermia you will use different degrees of warmth. So if somebody is in contact with 40 degree continuously, it can cause skin damage. So you have to be very careful. The forced air should not go directly on the skin when you're using high temperature. And you should frequently, like she said, every 15 minutes you check the temperature and bring it down to say 38 or whatever so that it is safe. And so frequent measurement, thinking about hypothermia and thinking about all the ways in which you can prevent or reverse hypothermia, which was clearly demonstrated in the role play. So over to you, Shubha.
Good afternoon, everyone. So I think it's been well demonstrated today that why temperature is included in the vitals. So we check for pulse, blood pressure, temperature is also one of the vitals because it may reflect an underlying physiological abnormality, or by itself it may lead to many other complications. So moving on to quiz now. I request everyone to join using the scanner. I think just one more, 50, and then we can start, 51. Okay, the first question today. What is the antidote for paracetamol poisoning? Paracetamol is a drug which is very commonly used, abused. Is it atropine, naloxone, and acetylcysteine? Great. And acetylcysteine is the right answer. Majority got it right. So naloxone is for opioid overdose. Moving on to the second question. Which is the drug which is used to prevent tumor lysis syndrome? Is it allopurinol? Is it warfarin? Is it insulin? Even if we don't know much about tumor lysis syndrome, I think by the drugs, by the options, we get a fair idea. So if we know the mechanism of action, then it'll be easier. Yeah, so allopurinol is basically used to prevent tumor lysis syndrome, which is commonly seen after chemotherapy for leukemias and lymphomas most commonly. Okay, in hypothermia, which complication is most common? Is it hypoglycemia? Is it hypertension? Or is it ventricular arrhythmia? So like I mentioned, hypothermia by itself can lead to other complications. So which is most common? Yeah, I think we had a good session. It can lead to ventricular arrhythmias. It is very dangerous, that is why. Okay. I hope people do identify their names. The chocolates are on the way today. Not a component of lethal triad of trauma. Is it metabolic alkalosis, hypothermia, or coagulopathy? I think I should expect 100% for this question today. We'll see. Okay, so it is metabolic acidosis basically. That is a component of lethal triad of trauma, and hypothermia is obviously there, and coagulopathy is there. Platelet transfusion before major surgery is usually recommended at what level of platelet count? Is it less than 20,000? Is it less than 10,000? Or is it less than 50,000? So thrombocytopenia by itself is not an indication. It depends on the level and whether a major surgery is contemplated or not. And the guideline says that it should be less than 50,000 and if a patient is planned for major surgery. For an asymptomatic patient, if it is less than 10,000, then anyway we'll give a platelet transfusion. But for a patient who is requiring, we know that the patient is being planned for a major surgery, less than 50,000 becomes an indication for transfusion, not 10,000. Something to learn. Which of the following blood components does not require a cross match before the transfusion? We always insist on a cross matching for any transfusion of blood or blood products. Which of the following does not require? Is it the platelet, whole blood, or packed RBC? Yeah, it is the platelet, even though they may want an AVO compatibility at the minimum, but still it does not require a proper cross-matching before the transfusion of a platelet, especially for emergencies. Whereas for packed cell and whole blood transfusion, you definitely need to do a cross-match. It may lead to severe transfusion reactions otherwise. HBOT is used in following procedure except people have to know the full form of HBOT, I hope. Is it chronic wound, decompression sickness, or kidney stone? In which of the following cases HBOT is not used? Okay, decompression sickness is actually one of the indication of hyperbaric oxygen therapy. So HBOT stands for high pressurized oxygen you're giving. Decompression sickness is one of the major indication for it actually. Yeah. So my multiple choice questions usually have a lot of except. Don't jump into conclusions before. Yeah. So chronic wound gas gangrene is also an indication. Diabetic foot not healing. Again, you refer patients for hyperbaric oxygen therapy. Kidney stone, not really. Three more questions. Most common cause of diabetic foot ulcer. So there are obviously a lot of causes of diabetic foot ulcer. Is it the underlying neuropathy? Is it an underlying vascular compromise, or is it because of trauma? So a diabetic foot ulcer is usually multimodal. Great. So neuropathy is the most common cause of a diabetic foot ulcer. It's not vascular or trauma. Fever in neutropenic patient is defined as a lot about temperatures today. Is it temperature more than 37.5 or more than 38 or more than 39 degrees? So febrile neutropenia, again a very common complication with chemotherapy. I think people can take a wild guess. It's actually 38 degrees. We'll have the last question for today. Sputum seen in acute pulmonary edema. I think this is basic. Pink frothy sputum. Is it thick mucus sputum? Is it green sputum? Okay, it is not thick mucus. That's why I put it specifically in the option that it is typically a pink frothy sputum which you get in acute pulmonary edema, and green sputum, of course, you get it with Pseudomonas infections. Who's Clippy? Mars. Sorry, Mars is second. Who's Lola? Acha, I thought you were Lola. You're usually Lola. Lola. Second is. Thank you.
I'm Dr. Gayatri. Everyone knows me.
Mars. Mars, Clippy.
Meghala MS Sotista.
Sangeetak.
Sangeeta from MSOT.
Thank you everyone once again.